Hi, and welcome to this podcast. The podcast today is with a friend of mine from the Netherlands, which is Hans van Helviort. And Hans, you've been around for ages, and when we just that's not negatively meant, but we
It's
just
a good
talked.
start, Brian.
We were off air, yeah, by offending the guest. I'm really sorry about that. You said you've been around for 40 years as a physiotherapist, more or less.
Almost. Yeah.
Almost 40 years. Well, congratulations on that, Hans. That's an achievement in itself. Um, in the period of time that I've known you, we've met at conferences around the globe. You've worked with people with radicular pain, and recently you published the article "Effectiveness and Cost Effectiveness of Mechanical Diagnosis and Treatment combined with transforaminal epidural steroid injections for patient on a waiting list for surgery for chronic lumbar herniated disc, a randomized controlled trial and economic evaluation." That's
Yes.
like very long title, but it's also a very interesting combined treatment. And that doesn't say a lot about you, Hans, except that it's your favorite area of interest within physiotherapy. So, if we're just putting the article to the side a little and let you introduce yourself, could you be so kind to do that?
All right. Yeah. Thanks for the introduction. For first, yeah, 39 years. I think I'm in physical therapy, so that's a really long time. Um, but anyway, what will I tell you? So yeah, I'm 62 at the moment, and started when I was 23. Um, as a physical therapist in a nursing home. There was no work at that moment in the Netherlands, and I had to do my social service because I rejected to go into the military service. So I had to do some social service on that. And I stayed there for 2 years. I could stay there after my social service and saw a lot of old people, which was good for me because I had no idea what to do with them. And so it was a nice learning experience, actually, not in physical therapy sense, but in more in relation sense with
Yeah.
dealing with all the people, dealing with end of life, dealing with all those issues which as a 23-year-old you were not thinking about. Um, and then I was happy to find a job in a physical therapy practice. In the time being, I did my manual therapy education in the Netherlands and in Switzerland. I'm a manual therapist trained in the Maitland system. Um, and I got that job because I was a manual therapist already. So started there in a normal clinic, a good running clinic, and seeing patients, all sort of patients. But actually, I felt like um, my was on the spine already. I was not interested in doing rehab for knees or for ankles or for that sort of stuff. So I was always interested in the spine. And with that interest, I started to realize that I didn't know anything. So I had to I went to a lot of courses at that moment. I've seen almost every Stanley Paris, David Lamb, all the old school, FGent, Carlton Born, all the people I could go to, I would go to. And at a certain moment, I thought I would like to go on holidays in New Zealand. So I thought, oh, let's do another course there as well. So I ended up with Robin McKenzie in his clinic in 92, and I did my diploma program there. And then at a certain moment, I thought, wow, this is really how I also feel. I would like to coach people because I felt like doing all those things, doing a half hour of mobilization or some manipulation on a patient, and then I see the patient back a week later, not knowing what the patient would do during the week, but then blaming myself if the treatment had not worked, or saying, "Oh, I was really good in this patient because the treatment had so worked very well." Which is also not true, of course. So happy with that. And so starting to get more into self-treatment and self-management and focusing on that. And I felt like at that moment, I think in 95, I started doing my master's in psychology at the university in Antwerp. Finished that because I thought I really need to have that broader picture on human beings in with pain or with disability or whatever.
Yeah.
Um, yeah, so that was nice, and in between, Mackenzie called me and said, "Hey, you have to teach the Mackenzie stuff." Where I knew Mackenzie by that time a little bit, being a little bit black and white, and I thought, okay, let's say yes to this because I never thought about teaching. Um, so I started teaching. I didn't like it in the beginning because, of course, I was not a teacher. It's a different profession. I made all the mistakes I could make, I think. Sorry for all the first students in my groups. But anyway, at a certain time, I started to like to find out ways to educate and to hopefully doing better. I think I do better, but and I started to enjoy it. So that was always a thing I've been doing. So I do that for 30 years now, or even more. And during the years, I came in contact with a lot of manual medicine doctors who were sending me patients because they couldn't figure out, and I had to do that because in that time, of course, we had a disc model, and I was good in treating discs. I don't know what that means, but anyway, and that was the time, so around the end of the 90s. And then I was invited to step into a manual medicine clinic and being their consultant for their practice. And that was the first time when I started to think even more on spinal, and I got more and more people with radicular syndromes and what to do with that. And at a certain moment, I thought, okay, we have this radicular syndrome patient, and I make some big steps now, but
It's okay.
and sometimes I can do it really nicely mechanically. I can centralize that radicular pain and beautiful. But in other patients, I felt like if I move you 1 millimeter, they scream it out, and it's so painful in the leg and blah blah blah.
Yeah.
That I thought, so what is that? And of course, reading about it and knowing that there is some chemistry going on when a disc is herniated, then I thought, isn't it strange that we sort of trying to do something mechanical, but maybe there is some chemistry going on as well. And are we able to change that as a physical therapist, or do we need some anti-inflammatories on that as an example? Because there's where I ended up. So then I discussed that with Michiel Schepers, who is the director of the Rugpoli where I work now. And I went to Charlie April's clinic
Yeah.
in New Orleans,
Yeah.
being with him for a long week. And Mark Leslett was doing his PhD
Yeah.
there.
He did his
So
PhD there.
I did some inclusion for his papers, and so Charlie sticking needles in necks and in backs, and I thought, wow, what is this? You know. And then I met that doctor in the Netherlands, and he said, "Oh, can I go there? Can I see that?" So I will ask. So I phoned Charlie, said, "Hey, I have this interested doctor." "Oh yes, send him." So I phoned Michiel back and said, "Hey, Michiel, you can go there. This is the number. Just ask him, and you can go there." And I thought he will never go there. It's just a blah blah blah, you know.
Yeah.
And then a month later, he phoned me and said, "Hey, thank you so much for getting me invited there. I I bought my first fluoroscope. We're gonna start, so we have to discuss how to do this." And then so we started with all sort of ideas on I doing the mechanical part, he's doing the chemical part, and so and from that the first Rugpoli was created, and then another one in the east side of the country where I was involved in, and now I'm in the south of the Netherlands having my own clinic in, but we all work in the same perspective.
Yeah.
Um, where I think it's still logical to if you focus, and that's my piece of cake, focusing more on radicular syndrome than anything else, or at least that's the patients I get. Yeah, I think it's logical to have some mechanical influence, the pressure of the disc, or a very small foramen or whatever you have, which is hitting the nerve, or some kyst or whatever, and then having some chemistry going on, and trying to find out which people need some anti-inflammatories on that, where after that I can start, and that's where the studies are about, I think. Is
Yeah.
that
Yeah. Yeah. That's fine, Hans. So at the clinic where you are, and you're the one that you're part owner at. What are there's a neurosurgeon and then there's the physios, and do you have other kind of colleagues?
We have our own, so we have our own MRI. We have our own neurologist, rheumatologist, anesthesiologist, and some manual medicine doctors who are all trained also in doing the simple like transforaminals and facet joint blocks and SI joint blocks and that sort of stuff.
Okay. Okay.
So we are a pain management clinic. That's how it's called, an anesthesiology clinic.
Yeah.
But the difference with a hospital anesthesiology clinic is that we are trying to stay away from the injection stuff and trying to do a lot of conservative management. And to make that a little bit more specific, we are not. So we see a lot of very chronic pain patients. But if the overload of nociplastic pain or psychosocial issues are that big, then we work together with other clinics because that's not the area we are.
Okay.
I think to make it in the biopsychosocial area, of course, I'm dealing with fear for movement every day. I'm dealing with cognition problems every day. People think, oh, my spine is totally arthrotic. Now I can't be helped anymore. So I'll talk about that, of course. But if there are like depression, anxiety, really more psychological problems, we send them off to a clinic where we work closely with, and they do the more psychosocial area where we do more the bio part and all the things we can deal with that.
Yeah. So that's within your scope.
Yeah.
Um, over the years, you've talked about this combined treatment, Hans. And so what's the background for suddenly making like what did you see in clinical practice that made you think this we need to do a study on this? What did you notice when they saw
Yeah,
with
good
the
question.
needle and when they saw with the guy with the mechanical eval?
Yeah, yeah. The simple thinking was reading articles on how does a herniated disc regress, what's happening around the nerve root, and seeing all those articles with all the stuff on all the chemicals going around there and itching the nerve and also the compression on the nerve, where I think we will come back to that because I have another idea on compression than the radiologist is having, but. I thought sometimes I really can nicely work with it, and I can get them moving and maybe centralize their pain, which is really nice. But sometimes I have no millimeter to move, and the pain is already like shooting in the leg and painful, and patients don't sleep, and they are very stiff in the morning, and all those like chemical sort of inflamed type of symptoms. And I thought, isn't it logical to just to combine those two? So
Yeah.
try to reduce the inflammation a bit, and I can work further. That was just the first start. It's just a sort of what I thought was logical thinking. So we just started to do injections on every single leg pain, and if there was what
Yeah, yeah.
the radiologist is saying, compression on the nerve root. Um, and I was trying to do my thing and seeing patients back afterwards, seeing if they need another injection. But that was all. Nobody did it. So I was just going on by doing and getting more specific sense on it, I think.
Yeah.
Um, where and reading literature on transforaminal injections or caudal epidural injections, all those different types of injections, and reading the conflicting evidence on them. So if I'm black and white now, we know that transforaminal epidural injections on herniated discs are reducing pain for a short time
Yeah.
frame. They don't have a long-term
Uh-uh.
effect. And then I was looking at our patients. Oh wow! If we combine them, we get this long-term effect. So that was actually the start and we started really in the bar with my colleague who does the injections, writing down on the little plate underneath your glass, like this is our protocol. This is what we're gonna do. So we did a pilot, and then we found out, oh, this is working pretty well. And then we did that official first study in 2014,
Yeah.
published in Pain Medicine, where we just counted, like it was just a prospective cohort study, where you just measure your leg pain, back pain. We did hospital anxiety and depression scale, GP, general perceived effect. And so it was just a very simple setup of a study. And that attracted a lot of attention, actually. And actually, I was invited by the University of Amsterdam to look at that and maybe start a PhD on that, because the effect was so big.
On the
that they said,
pilot, right?
Sorry?
On the pilot, the effect on the pilot.
Yeah, the
Yeah,
effect
yeah,
on that study in 2014 was so big that I
yeah.
said, this is so innovative as well. So maybe we can ask for innovative grants from the
Yeah.
government. And we applied for that and we got it. So,
Right.
and then it took a long, long time to actually now have published the randomized control trial with all the problems in there as well.
Yeah. Academia and research, right?
Yeah.
So Hans, you've made this RCT and you have two arms.
Yeah.
And you basically outline the arms. You have one arm doing what and another arm doing what.
Yeah. So the one arm is what we call the combined therapy, where so it's actually the same sort of protocol as I've used in the first article, which you can read there if you want to read about it.
Yeah. So it's patient on a waiting list for surgery, right?
And the other arm is patients waiting on the waiting list for surgery.
Yeah.
That should be the case.
Yeah.
And I have troubles there because we come later on that. But that are the two arms.
Yeah.
And then the main outcome measurement, the primary outcome measurement, is those patients on the waiting list, they will get surgery or maybe not, because they're still on the waiting list, get better on their own, or find a physical therapist who does something nice to them. And the combined treatment patients, how many of those patients need surgery after the treatment?
Yeah.
Okay. And so we did a power calculation and we lifted that a bit up because of all the problems every RCT has with not enough patients and not enough preciseness and etc. And our goal was we needed to have a difference in surgery rate to be cost effective if we have a reduction of 30%.
Okay. Yeah.
Of surgeries. Okay. So a difference on the waiting list, let's say, and so what it ended up with, the people on the waiting list, they had surgery, I think from my head, 72%, and the people who were having combined treatment, still 32% got surgery. So we had at the end we ended up with a difference of 44%. But, and then the big buts are there. We didn't get our 146 people from our power calculation. We only ended up with half of them, which is, I think, very strange, because at the beginning of the study, we got patients and got patients and got patients. And then all in a sudden, halfway the study, we didn't get any patients anymore. And of course, I don't have evidence why that happened. But if I was listening around, then I phoned the neurosurgeon who was involved in the research group. I said, how is that possible? Where are the patients? Said, yeah, I don't see that many herniated disc patients. Where I have big question marks, because as I told you in our before talk, the Netherlands is the second in the world doing herniated disc surgery on radicular syndrome. The Danes are the third in the world.
Yeah. We're only third.
It's America first. It's America first. And we had 7 hospitals involved in the study. So it's, for me, I can't say anything. I don't know, but I never get a finger behind that. But I found that very strange. Another thing was that a neurosurgeon said to me, yeah, I see a lot of stenotic patients, and those stenotic patients, I do surgery on. And then if I see this really nice and fresh herniated disc patients, I'm not going to send that into that trial because it's so fun to do this fresh surgery. It's giving me so much happiness to do that. But that's selection bias. And there is a lot of selection bias in the study where I think that's why we ended up with half of the people. And the problem with the grant is if you have for a certain amount of time, you don't include patients, the grant giver is going to, the government was saying, we're going to stop the grant.
Okay.
So they stopped the grant. And then the thing is that on the patients you have to follow them up for sure. And you have to publish on the patients you have. But of course, that grades down the randomized control trial because you didn't reach your power calculation.
Yeah.
If you read the discussion, we come back on that because we say, yes, we haven't reached the power calculation, but we have reached even 1/3 better than the 30%. We did 44% difference. So even with half of the patients, we already are very significant in reducing surgery rates.
Yeah.
So you can argue the power calculation in
Yeah.
itself.
There's always like pros and cons when you're looking at numbers, right? And you can like flip them around, but that's interesting. And I also think it's been published in in quite a good paper. So it can't be that bad just because of the power calculation, Hans. Then you would have
No, no,
a
no,
lot
no.
of
No, I think it's still interesting. I was not happy because other things which happened. Got a patient myself coming to my clinic having no herniated disc at the MRI, where I thought, okay, this is strange. But I had to prove that they shouldn't have surgery. Not the surgeon has to prove that he did surgery. So that was strange. Another patient came in. I think I saw 10 patients of the 38 we did in our group, I think, from my head. Another patient came in and said, yeah, I want to have that injection because the neurosurgeon has said that would help for the pain I have now, but I'm planned in 3 weeks, which is not being on a waiting list, waiting for surgery. So they were planned already having, so that's impact, that's selection bias. It's so many of those things. I can go on and on with all that
Oh yeah,
sort
I
of
think we
impact,
got the
which is,
plot. Yeah.
but you can't write that down because you don't have evidence for that, and so that's a pity.
Okay.
So if I have all those ideas in my mind, I'm worried about other randomized control trials because they will have the same problems
Yeah, yeah.
in their dealing
In their
with
domain.
patients.
Yeah.
But for this one, I think although all those things happened, it's still reliable. It's still having a big chance to reduce surgery. And I think it really could have been much bigger because my cohort study showed that 87% of the patients didn't have surgery at the end. It was 78 for the people who had injections, but and there you see the difference also in patients. In my pilot study, I had I had 21 patients, 40 patients were still centralizers. So they got only MDT without epidural injections. So we kicked them out the study because I was interested in how we did in combining the
Yeah,
two.
yeah, of course.
But
Yeah.
if you count them together, it was 78 with the people who had an injection saved for surgery. But if you put them together, it was 87%, which is
Okay.
bigger. And
Yeah.
now we're still ending up with almost 70% being not having surgery, who were all listed for surgery.
Yeah.
And at least also seen by the neurosurgeon. That's what I wanted, because they decide if they do surgery or not.
So just to summarize, if they get the combined treatment, there's around 70% that avoid surgery.
Yeah.
Yeah.
All a very chronic radicular syndrome patient, which
Okay.
is a thing as well, which was way more chronic than my pilot.
Okay.
They were having more than 3 months, but now a lot of patients were like up to 1 year having problems.
Okay. And that's a reduction in 44%.
Yeah,
Yeah.
yeah, between the groups.
Yeah. Yeah. I get that.
So I had a reduction of the patients in our group. 68% were having not surgery. Where the people in the waiting list group, they all got surgery, or not all, but the difference between the groups were 44%, which when we were calculating, that would have been cost effective, which came out as well.
Yeah.
And I think that so the one thing is that we still could prove that we can reduce surgery. We still have this long-term effect when you combine epidurals, which only have a small effect, and I will come back on that because I think I know why that is. But if you combine them, you get this long-term effect of a year, which is nice. So adding MDT towards an epidural injection is really creating longevity of the outcome.
Yeah.
And I think what we did with the cost effectiveness analysis was really thoroughly done with different perspectives, so that policymakers can decide if they go for it or not. And yes, it was for societal costs. So that's all the costs. It's the healthcare costs and work, absenteeism, presenteeism, all those things together. They give us a chance of like around 65% that we are cost effective, which is not really great, but it's not small as well. But if you look at healthcare cost on its own, so the combined treatment with the same effect as surgery is having this 97% chance that it's cost effective. So that's really high.
Yeah.
And giving you enough profit to do that. So if our health insurances in the Netherlands would think, wow, this sounds good for us, they can change the policy, not going to the surgeon first, but try to do MDT combined with some transforaminals first.
Yeah. Yeah, I agree. I think it's a clever move to start looking more at the cost effectiveness.
Yeah, yeah.
And especially look at different domains like you did.
Yeah. Yeah, and I think that's not many studies have done like 5 different domains, and I am not a specialist in that. It's way too difficult for my brain. I'm just a simple clinician, but yes, that was done pretty thoroughly, and it's also a nice way of looking at it. And I think other studies should do that as well, because that really looks at living years in good health, and so the QALYs. How much is a QALY word, and how much chance you have that you get this more lives in good health using those QALYs. And I'm not a specialist in it. I find it very difficult to follow, but it's a nice result, and it's nicely done, I think.
Yeah, and I think it's something that over the years it hasn't been talked, or at least I haven't stumbled over it, but some people starting talking more about it, and I think it's quite important. And I think clinicians are involved in those studies, not just you, Hans, but because I mentioned it before we went on air, because you were too humble to mention. But some people are like, oh, we've made this study and it's cost effectiveness. So I think everybody kind of in studies like this need to look at the cost effectiveness, and then maybe treating. And now I'm gonna say the word we're not allowed to say. Maybe treating the subgroup to see if it's subgroup specific, and then cost effectiveness. You get me?
Yeah, and cost effectiveness is a difficult concept. It's based on very, as you say, different domains of looking at it, and then it's also depending on your economic situation in your country. In our country, a QALY is equal to 20,000 euros. So that means it gets cost effective if your costs are way underneath that 20,000 euros, because that's what we want to pay for a better 1 year longer life in a good health.
Okay. Yeah. See, now
so maybe Denmark says, oh no, we only have 10,000 or maybe 50,000. I've no idea what a QALY in
Denmark costs. And I haven't got that either. So it also makes a difficult thing to discuss, actually.
Yeah, we don't need to. But in that way, it's nice to look at it that way, because it says something about the quantity, but also the quality of the life.
Yeah.
Which is interesting, I think.
Okay. Hans, you said, just for the clinicians listening, that you had some idea the inflammation around the nerve root. Which are you okay with, like, or maybe I didn't prepare you on that one, but it just popped up in my mind. Which clinical signs do you listen to
Yeah, yeah.
when you when you
Yeah,
think there's
thanks for that
inflammation
question,
involved?
because I think that's the question which we are researching now. Um, so we do see people who do really well on an epidural. Sometimes they have had two and they're absolutely pain-free. They can do everything. They're totally happy. They don't need mechanical treatment with it. And I'm interested in, how do I recognize those people who have this overload of chemistry going on? And actually, there is a nice paper done by John Ford from the Melbourne University in 2020 in British Medical Journal in BMG. And he looked at people who had a herniated disc, and he took out the material very close to the disc. And he was looking to all those neuropeptides which are increasing inflammation and
Yeah,
how much was in there. And then as a control, he took out in people who had scoliosis surgery. They also need to take out sometimes some disc material, and looked if there were some neuropeptides in there. There weren't. And then he brought it back to the clinic because he's a physical therapist. So he was seeing those patients with the herniated disc, the material very close to the nerve. And he was looking at all those inflammation markers. And the people with high inflammation markers, then he was looking back in what did this patient say?
yeah,
And so that's really interesting, because then you can say, okay, I can listen to those things. And it's very simple. And it's actually pretty simple if you think in modic changes and having inflammation from that. What do the people say? They can't sleep. So he had an inflammation prediction score where
yeah.
you have 4 questions, and 3 of the 4 you need to be positive, which is constant pain. So there is no time in the day that I don't feel anything in my leg. I have this really disturbing night pain. I wake up, I have to go out of bed, I have to take pain medication, I have to walk around. All those people who are really disturbed in their sleep. Morning stiffness taking longer than 60 minutes. And the last one is, if I do a short walk, like 50 meters, does that help your leg pain? If not, then you have 4 out of 4 positive. And that would be a high inflammation situation, together with, if you have flexion, which is major loss in our schedule, like 0 to 30 degrees flexion, big loss of flexion, and back pain, not leg pain, but back pain lower than 5. So that's the whole prediction rule. And the prediction rule is 94%, almost, I think 93.7% positive in predicting that there are inflammation markers very close to the nerve root. The whole thing with, and that's where my interest is now, if you look at those injections, they have conflicting evidence.
Yeah, they
It
do.
works, it
To my
doesn't work.
knowledge, at least to my
It's not
knowledge.
better than a placebo. Oh, it's much better than a placebo. And they use all the same the same articles to do a review, and reviews are everywhere. We are busy now with doing a review on inclusion criteria for epidural injections, and no single randomized controlled trial is looking at, are there any signs of inflammation where my injection is corticosteroids reducing inflammation. So they can't explain me, if there is no inflammation, why would a corticosteroid injection work? Because if there is no inflammation, an anti-inflammatory doesn't work. So that's maybe why there's so much spreading of it works and it doesn't work.
Yeah, yeah.
So my next trial of my next the first cohort will be looking at those inflammation signs. I will do that as a physical therapist together with my colleagues in the other clinics. We write that down. Then they get an injection, because there's not a rule yet. So they get an injection, and then afterwards we're gonna score how people do. And I'm I did a pilot already. I didn't write it down, so this is what you have to believe on my blue
Yeah,
eyes.
yeah.
It makes
You
a difference.
Dutch. You just do things.
Yeah, it makes a difference. If it's inflamed, like in that inflammation score,
Yeah.
then I have a much bigger chance that my corticosteroids are going to work on
Is
that
it
patient.
is it then just working for 2, 3 weeks as we see, or
Oh
is it
no,
a
no, you
long?
see a lot of, yeah, but because we always combine it, but no, they can work for a long time. They can work for a year. In the pilot, I had like 16% of the patients who only got 2 injections and nothing else. They got some preventative advice based on the McKenzie principles, but they did well after. Actually, that was the best group. So I thought at the end, I thought that were the really, so inflammation was the main factor. It
Yeah.
was not mechanical pressure.
No, no.
Okay.
Yeah.
Where other people, they didn't have an effect, or almost no effect on, or a little bit of effect on the inflammation. So they got a little bit less leg pain, and then they start to centralize. That's where my combination comes in. And I had people where I couldn't do anything, I couldn't move, and they didn't get any better on the injections as well.
Yeah.
So but my interest is there. If you look better to inflammation scores, do we get a better result of the transforaminals? That's one. And can we then get a better result from combining it?
Yeah,
That's the
yeah,
second
yeah.
question.
Okay.
Yeah. Yeah.
Well, that interesting, Hans. What would you, just one of the final questions, Hans, what would you like, I always ask this question, what would you advise young clinicians working with radicular symptoms?
I
Um,
think so. I give this
would be
master classes worldwide on to young people on or mostly they're younger than mine. Maybe that's why I call them young.
That's
Um,
a good strategy.
but I would love to. So my goal always is the same thing: is you have to decide to McKenzie people. Some people keep on searching for centralization in the radicular syndrome, but some people they just don't centralize. So stop it. Don't think that you can do something specific in a way of direction specific exercise,
Yeah,
and stop searching for it. If it's not changing neurology, if it's not changing range of motion, and your pain is just releasing a little bit by moving, that's not a centralizer,
no, no.
So don't search for it till you are sort of at the sixth treatment or whatever, because that's way too long. That's one. So how do you decide when to stop searching for centralization? That's an important one. And the other thing is, if it's inflamed, it's inflamed. If you have a bruise, don't push it.
Yeah,
So not treating is a good option as well. And how do you recognize that patients? And I would love to see people listening to that simple questions, because it's not higher mathematics, is it? It's just simple questions
yeah,
you can ask, and you get already an idea on, wow, inflammation here is a big thing. I know that Denmark is not the easiest way to get injections. Maybe that changed over the years, but when I was back, when did I do my masterclass? It's one of the first ones in 2018. Then the comments were, we can't order them here.
yeah, yeah. No,
Maybe
it's
that
the
changed.
same, more or less, Hans. More or less the same is my experience.
Yeah, all right.
Unless
Yeah,
you
but
know,
then even you can think in medication. So go back to your general practitioner. Find positions where people do feel well in. Don't push it. Give good advice on how to improve loading and that sort of stuff. Um, but doing nothing, I think that's one of the options you have, and feeling well with that. If it's
yeah,
inflamed, it's inflamed. And patients really like that sort of metaphors, like, hey, it's a bruise in your nerve. It's not, if you push it, you start to wiggle around with your leg for another 2 hours, then that's not a good idea to do. Because if you push it more, it swells up more, and it's get less space, and you get more crazy during the night. So don't do it. Lie
yeah,
down in a certain position, or just have very small amounts of movement, trying to say stay away from it, get some
yeah.
good medication.
at that current point in time where it's still very inflamed.
Yeah, yeah,
Yeah,
absolutely. And
yeah,
if it dies out, you're gonna be the coach to
yeah,
get that patient moving again, because that's the important part.
yeah. Well, Hans, thanks for sharing your article, and thanks for sharing your clinical experience. Sorry for going a bit off the script, but it just came very obvious that we needed to talk about some of the clinical reflections that made you go down this path and research in it. So thank you for putting your
And you,
time
thanks
into
for
the study.
inviting me for this. I feel I always get, I still get, how do you say that? Excited to talk about it. So
Well,
thanks
that's
for
not
that.
a bad thing, Hans.
No,
That
no,
just,
I don't
that
see
just
it as a
tells me
bad thing.
that yeah, you're still doing what you're good at and what you like.
All right. Thank you so much.
Thank you, Hans.